So the Healthcare Commission inspection system didn't seem to pay that much attention to patient experience. It may have measured other important things like whether people survived, value for money, but it wasn't actually that focused on patient experience. So what matters? And I think very, very clear. The things that we know, treating people with dignity and respect, this amazing correlation which we just need to keep going back to, because of course in different places dignity and respect means different things, but there are no places in Britain or England where everybody thinks they get no dignity and respect, but they absolutely loved the way they were treated. Top left-hand side, nobody there at all. Similarly, nobody in the bottom right-hand side, loads of dignity and respect, but they hated the way they were treated. In fact, you might as well not bother asking whether you like the way you were treated. Just ask, were you treated with dignity and respect? It means effectively the same thing. And real challenges in places like Newham, in places like Mayday, compared to places like Norfolk and Newcastle. And some good reasons behind that. Similarly, examination privacy. You know, generally, again, a strong relationship. St Mary's, Queen Mary's Sidcup does quite well on that. It's obviously quite, you know, you get plenty of privacy, but they don't like the care or something else that happens to them. But generally, again, a strong relationship. Again, the same sorts of trusts at the bottom. Other things we might look at, a doctor who actually, as well as being brilliant medically and clinically, can actually explain things in simple language to the people they're trying to treat. We actually employ as our chief statistician a fully trained medical doctor who decided, when you meet him, if you ever met him, you'd understand why he switched careers to statistics and computers, because his complete inability to communicate with anybody, which is probably just as well. He made the right choice. But there are still many people in practice who have problems with this. And if you've read Malcolm Gladwell's Blink, you'll remember that really interesting example where he says that he can predict the likelihood of a physician in the United States of America being sued simply by watching the first 20 seconds of the interaction with a patient. And so there is, you know, and clearly it stands out here. We have to explain things like side effects, the treatment, etc., and make time for people. Because, of course, one of the backdrops to many of the changes in an investment and reform in public service has been that although people will often say public services are now hitting the targets, they may also say, of course, we're missing the point. You know, the nurse who will do something, do the bedpan, but can't smile, doesn't know how to smile. I know that's, of course, illegal, but, you know, mustn't ever suggest that nurses should ever do that because they're all got, you know, PhDs now, but occasionally this might help. Involving people in decision-making. You know, they don't want to come and sit in meetings with weird people like us and decide how to run the NHS, despite politicians thinking it's a good idea for them. They do want to be asked, you know, as I did, I had a lump on my back recently and I was involved in decision-making. I asked the registrar, what would you do? And you said, well, I can look at it and see what happens to it if it grows any larger. I can cut a bit out of it and take it away and examine it, or I can chop it off. And I'm sort of, well, OK, what would you do? I'd chop it off. So I now have a large scar on my back. But I was involved, and I'm happy with that process. And again, these big differences, again, right across Britain between places that seem to do that and places that don't. What else might help? Pain management. You know, we don't want to be in pain. But again, a huge variation across the country between how happy people are with pain control and where we're not. And of course, again, a very strong relationship. And we know, of course, with the Hawthorne effect, if you're going to do something nasty to them, do it about a third of the way into the treatment, not right at the end. You know, and let them remember the nice bit. What else might help? Cleanliness. You know, the public are not experts about clinical success factors and what good looks like. They really can't tell when they're unconscious what is really going on to them. They can form general impressions about whether or not the hospital is clean. Very similar with airlines, actually. We do a lot of work for airlines on things like, you know, general quality of service. And obviously these days, with planes dropping into the Atlantic, things like safety. The general criteria people will use to judge whether an aeroplane is safe or not is how clean it is inside. And it's the same with hospitals. And so if you take two hospitals with the same level of MRSA or C. difficile, and one of those trusts makes sure that its cleaning teams don't work in the dead of night so that they can clean effectively and simply, but actually clean when footfall is highest, at the busiest time of day, in high visibility jackets, that will have a higher level of satisfaction than the one that does the optimal process, because some of this is about reassurance. And interestingly, of course, the public are not utterly insane. There is a correlation between how likely the hospital is to have a lot of MRSA and whether or not the public believe the hospital is clean. In the years before the Tunbridge and Malling disaster, we were doing focus groups down there for the Department of Health, and we were hearing these stories about blood on the walls, apple cores lying around the area, etc. And people notice this stuff. Is anybody here from Hemel Hempstead? which I think is about to be demolished, but I keep using this joke. I knew Hemel wasn't as good as it should be when I walked to see my dying grandfather day after day past the same squashed styrofoam cup of coffee on the stairs from the car park. Not anywhere near any clinical area, but it seemed to tell me a lot about how that hospital felt about itself. Now, of course, I should have picked it up and cleaned the floor myself, but I'm a sort of consumer, so I didn't. So overall then, we know that if we can get these things right, that is the thing. Those are the things to focus on. And I think what's interesting is we can go on being, we can change these in innovative ways, we can do clever things, but it is these things that we know make the biggest difference to how people feel. And if you crunch them all together, overall, they explain, just those 7 things, explain virtually everything about how people will feel about inpatient care. So do a bit more on these things, focus on those things. And that means our staff who work for us being clear about what those things are. You know, if we were running McDonald's, of course, much less complicated, but there would be absolute clarity amongst that whole sort of time and motion study. When you smile, the questions you ask, all of that stuff is calibrated precisely to try and optimize experience. But in the NHS, of course, we're too busy doing other things. And generally, what we find as well, of course, if you're looking at other factors, the more people know about you, the more they like you. This is just looking across a region at a range of individual hospitals and looking at how favourably disposed people are to them and how likely they are to choose them as we continue to roll out the choice agenda with how much they feel they know about them. And the rule of thumb is exactly the same as in all walks of life. Familiarity does not breed contempt. The more they know about you or feel they know about you, the more they will like you and the more likely they are to choose you. So in this example, Addenbrooke's swamps the other trusts in terms of familiarity and favourability. And when we asked people across a large catchment area about Addenbrooke's, one of the things we found interesting is that many people thought it was their local trust and they were actually going to be driving past other hospitals, increasing their journey time simply because of its level of familiarity, not because they necessarily thought it was better. And interestingly, when we look at performance as measured by auditors, boring, pointy-headed auditors, looking at value for money by individual trusts, one of the things that we found was that the trusts that were scored as excellent or good were far more likely to say that they had a marketing strategy than the ones rated fair or weak. Now, I'm not arguing that the way to be good is just to go and spend lots of money on press releases, PR departments, websites, broadcasting SIM messages to people, etc. That clearly, in the words of Steve Bundred of the Audit Commission, you can only polish a turd so far. This is not about just going out and saying, yes, it's very good and clean here, come here, it'll all be fine. But nevertheless, assuming a standard level of care, if you take 2 hospitals, the one that is better at explaining what it does will be more likely to attract footfall, will be better regarded, and if there are going to be cuts and closures, will be more likely to be defended by its local community. And interestingly, when we looked at expenditure on this, I thought this was interesting. Boring, pointy-headed auditors, looking at value for money. And what do we find? We find the ones that they rate as best are actually spending more on communications. So value for money is better when you spend lots more money on printing press releases, newsletters, etc., and hiring worthless PR people. Why would that be? Are the auditors insane? Well, I suggest probably not. And of course, the auditors don't actually look at this stuff. But what we're measuring here and what we're picking up is probably that those places that perform better, that are best run, are probably most interested in the community at large, are most interested in communicating what they do, and we find precisely the same pattern in local government. If you look at how the Audit Commission rates individual councils on use of resources, we see exactly the same pattern. The ones that actually spend the most on communications are actually better rated on use of resources than the ones that spend less. Now, I'm not arguing that spending lots of money on communications automatically works. I know of one organisation in the public service in Britain that sends out a newsletter to its residents every 2 weeks. And its ratings on keeping people informed and its profile are worse than another one that does it 4 times a year. So it is not, it is just lipstick on a pig. And you've got to sort out the pig first. But generally, people do want to know about the things that are available. They want to know what services are there, how do they access them, and that builds confidence.